Good morning. Welcome to this year's NTM lecture series for patients and families. We're very happy to have you. We just finished 2 days of sessions for providers, which was really quite good. We expect around 50 people here in the live event and about 500 are streaming in. So we're very excited for the interest in NTM. Before we get started, let me introduce my co-chair. Oh, first of all, I'm Chuck Daley. I head the Division of Mycobacterial and Respiratory Infections here at National Jewish. My co-chair is Michelle Haas. She's an associate professor in our division here at National Jewish. And today we'll be working together to try to moderate the sessions. The restrooms, most important thing, there's a sign right there. Just follow that out and then you curve around. I'd like to thank our exhibitors, the platinum sponsor, InsMed, and our conference exhibitors. And I encourage you during the break to go back there and get your answers or your questions answered directly at their booth. If you're interested in Wi-Fi, it is available. It's under the guest, NJH guest. You'll see a pop-up window and you need to put in your email. There's a URL link to access the slides online. It's also in your packet. Importantly, questions. We feel like we failed if we haven't answered your questions before you leave here. So we try to make time for questions. And at the end of the day, we have a block of time. So if we don't get to them in any particular session, write them down and we'll get to them at the end of the day. For those of you who are live streaming right now, please put your questions in the Q&A function in the Zoom. And we're going to try to get to as many as we can as we go through the day. At the end of the day, you'll get an email link to the conference evaluation. That's really important for us to hear back from you, what worked, what didn't work, what other ideas you may have for next year. These are going to be recorded and they'll be available in about 3 to 4 weeks on YouTube. And if you need any help, Nicia, Megan, Andrea, they're all here to help you. And of course, we are as well. So let's get started. I'm going to begin by just kind of giving a little background on NTM. When you leave here today, the most important thing is that you can spell NTM. That's a good start. We totally failed if you can't. Okay, what are these things? Non-tuberculous mycobacteria. Well, what are mycobacteria? Mycobacteria are a type of bacteria. It's a genus, Mycobacterium. The most famous is tuberculosis, Mycobacterium tuberculosis. Then the second most famous is probably leprosy, Mycobacterium leprae. All the rest, and the rest is a lot, about 200. So this is a genomic wheel. Each little name, which you cannot read, is a different species. So now close to 200 species of mycobacteria. And except for the TB and the leprae, we call them NTM, non-tuberculous mycobacteria. They all share a property we call acid fastness. And sometimes on your culture report, you'll see AFB, and that's what it's referring to. The acid fastness is how we see the organism in the microscope. So even though we have two famous brothers here, TB and leprosy by far much more common are NTM. And why are these things so tough? They survive in all kinds of conditions. We'll hear about some later. One of the things is they have a very thick cell wall. So we divide bacteria into different groups. One is called gram-negative bacteria. That would be like E. coli, Salmonella, Shigella. Then we have gram-positive. Those are staph and strep. And these are just depictions of how their cell wall is made up. And if we look to the right, mycobacteria has a thick cell wall. It is very difficult for drugs to penetrate that cell wall. And that is one of the reasons why it is so difficult to treat these infections. Now, the first probable description of NTM was MAC, and it was because chickens were getting tuberculosis, chicken tuberculosis. And it looked like the same disease that we saw in humans with tuberculosis. It would be in their lungs, and it would destroy their lungs. And this was described in the late 1800s in England. The first human cases of NTM were probably in the 1930s. And in 1943, one of the earliest actually publications on this was a case of a patient who had Mycobacterium avium complex, or MAC, also had silicosis. Silicosis is a form of lung disease from people who inhale silica. Often sandblasters, for example, would over time inhale the silica from the sand and get lung disease like you see here. The top part of the lungs is all white and inflamed and scarred. And that has historically been one of the risk factors for developing an NTM infection. And it goes all the way back to the 40s. But since then, things have changed a lot. So NTM prevalence is now increasing. We know that it's higher in older age groups, and in women have higher prevalences than men. In some countries, the US and Canada be two examples, we see more NTM patients than we see tuberculosis now. Bronchiectasis is by far the greatest risk factor for developing it, and it's increasing. What you see in this figure, these are the prevalence. So basically the number of cases per 100,000 population, and it comes from the Optum database. So this is a managed care claims database. And what we're looking at from 2008 to 2015 is the prevalence. In the top two lines, let's focus on those first. The very top line are people who have pulmonary NTM who have Medicare. So this is or excuse me, who are over 65. So this is a marker of age, and look how it is increasing between 2008 and 2015, really dramatic increase. Right below that line is Medicare, so both a proxy for age. The third line from the top of women. So women have a higher rate than men, and this has been shown in multiple epidemiologic studies, but in almost all categories between this time frame, it's increasing. This is from the same study, looking at the incidence, not the prevalence. So the incidence is the number of new cases per year, for example. 2008 to 2015, and you can see it varies by state. A lot of people are interested in these data because they want to know where to live and maybe where not to live. And if we go to 2008, we can see the darker colors are those that had rates of 6 per 100,000. To put that in some perspective, in the US, TB is less than 3 per 100,000. So it's double TB in some states. Now, traditionally, it's been in the southeastern US where we've seen higher rates of disease. Hawaii, unfortunately, tends to win every year, the highest rate in Hawaii. Florida is usually number 2 or 3. Louisiana's up there. But in this, let's go from 2008 to 15, and you can see the colors are darkening, meaning the rates are going up. And that's a fairly significant change across this. Now, there are also some states here that we go, why does that state have a high rate? You know, if we think that's mostly in Florida and Louisiana, wet, hot places, Hawaii, and we don't know the answer to this, but these are the data. And there's something happening in Arizona where we see such a high rate. And we can see across the United States, other states that have high rates, and we don't really know why. But what we know that this is happening, it's increasing. Now, how do we get these? They're everywhere. They're in the natural environment, they're in water, they're in soil, they're in treated water, they're in natural waters. They're also in our built environment, meaning our cities, our homes. This is a pipe. Please don't look in your pipes because this is what you may see, which is biofilm. Just gelatinous. If you go and drain your hot tub, you will get a gelatinous mass will come out of there, and that's biofilm. So we're exposed to this, and we'll hear a lot more about that from Dr. Honda later. But if it's everywhere, why don't we all get it? I mean, if we're drinking it and showering in it and swimming in it and gardening in it, why don't we all, everybody have NTM? Well, it turns out they're kind of wimpy bugs compared to tuberculosis, for example. And they have to find a way to get through, either through your immune system or your lungs to cause harm. Most people who have pulmonary mycobacterial infections, NTM, have underlying conditions. I already mentioned bronchiectasis, top of the list. But cystic fibrosis, which causes bronchiectasis, very high rate of developing pulmonary NTM. COPD is probably next in line. AAT means alpha-1 antitrypsin anomalies, which can produce COPD and also bronchiectasis, a genetic disorder. But basically anything that affects the lung puts a person at risk. Now, there are also people who don't have any lung disease and do not have any immune dysfunction. And we think probably they get a very big exposure from their environment through aerosolized water, through aerosolized soil. Maybe just living long enough in an endemic area is a risk. We don't know. And then this very interesting group that many people have heard of. These are women mostly. They're postmenopausal at the time of presentation. They are thin, a distinct body habitus, which is that they're tall, thin, and light. The term Lady Windermere, I'm just mentioning it because you've heard it, but we don't like the term, and we're trying to get rid of the term. It comes from Oscar Wilde's play, Lady Windermere's Fan. And the reason we don't like it, it has nothing to do with anything. Lady Windermere was a young, vivacious woman. There was nothing wrong with her. So why do we label her with a disease for eternity? So we're trying to get rid of that term. But the phenotype, the patient that it's referring to does exist. Tall, thin, light. This kind of new concept in medicine is trying to put together what happens in our body with what happens around us in terms of exposures. Within the body in the central circle here, risk factors for NTM can be based on sex, genetic susceptibility, increasing age, low body mass index. But there are things around us in our environment called the specific external environment and the general. The specific is things like shower biofilms, plumbing, exposure perhaps to gardening, things that you can control your exposure. But there are other environmental factors like mineral content that can determine the concentration in the soil or the water of NTM, water management systems. And very important, and you'll hear more about this, is climate and climate change. How will that impact NTM? All of those feed into us, our human selves, and can cause disease, can result in disease. And that's called the health risk and impact. This is kind of a new model we're all thinking through, because if you break it down in these steps, you see there are multiple places we have to try to learn more so that we can intervene and break some of the cycle of disease. Ultimately, when disease occurs, it can occur in two general categories. One here is the cavitary lung disease. This is a CT scan. That big black area is a cavity. It's a hole in the lung. And so it's a more advanced form of NTM lung disease, and it occurs mainly in smokers, more in men than women, tends to be in the upper lobe, which is what TB does. But then we have the other form, which is we call the bronchiectatic nodular form. This is more seen in women, right middle lobe, lingular predominance. You see these little clusters of grapes, that's areas of bronchiectasis. This has a better prognosis in general than the cavitary forms. But each form may need treatment, and the treatment will vary depending on which form. And I'll talk about that in just a bit. So today we're going to cover a lot of things. The patient, from the patient perspective to bronchiectasis, GERD, how we're going to treat the disease and how we monitor for side effects. Later, I'll talk about some new exciting things that are coming. And at the end of the day, as I said, be prepared. We'll have time for questions. So now I want to shift and introduce someone who's going to tell us about a very exciting new initiative occurring in the US, something that could impact all of you. John Torrance, who's coming forward. John is a longtime patient himself, patient advocate. He is now currently a patient ambassador for the COPD Foundation, and he's going to tell us briefly about this new initiative. John.
Thank you, Dr. Daley. Dr. Daley and his staff have indeed created a great environment today, incredible staff for great presentations. You'll see the top doctors, scientists, researchers, therapists talk to you today, and they know the most about this disease. I am none of those things. I am an ordinary guy who was minding my own business in 2009 when I started coughing. Coughing didn't end, couldn't find any relief for it, and I spent, maybe similar to you, the next 3 years trying to figure out why I was coughing. 5 doctors and many tests later, my local doctors were frustrated. They had an idea of what it might be, but they really couldn't give me any help. And they said, you need to go to National Jewish Health. And in contrast to those first 3 years of very frustrating care, I came to National Jewish Health in 2012. I received comprehensive care, a prompt diagnosis, and a plan for the future. So fast forward a little bit, and I realized that even though everyone said this is an incredibly rare disease, it seemed to run in my family. My mom had it, my sister had it, cousins had it. I'm thinking, there's something going on here. So I decided I needed to be about the best educated patient that I could be. So I attended every conference like this that I could find, did all my own research. Eventually, I aligned with the COPD Foundation. They have a bronchiectasis and NTM 360 division where they're doing a lot of research and working with these organizations. And for the last 5 years, I have been, as Dr. Daley says, a patient ambassador. So I talk to new patients who are a little concerned about what their future might be and try to give them an idea of, how we live with this, how we get along. And separately, I'd be happy to talk to any of you later on if you'd like to just chat patient to patient. But today I have something more important to talk about. If I can make my slide work. And this is the COPD Foundation is leading an effort in collaboration with NTM and with the leading institutions around the country to create a care center network, similar to those used by the cystic fibrosis group and pulmonary fibrosis, so that there will be centers of excellent care around the country where you get standard of care. And essentially, the level of excellence that you see here at National Jewish, we hope to replicate that in various places. So patients who aren't very close to National Jewish have a place they can go that is close to them. Our goals are to get the best possible patient care because we all deserve that kind of care. Our network will include healthcare professionals and patients, support for research and clinical trials, and we'll be increasing disease awareness in the community so local doctors know to refer patients into this network. And through these steps, we hope to increase the speed at which people get diagnosed and get productive in their treatments. Starting in May, we'll be accepting applications from healthcare centers if they want to be part of this network. So if you have a local healthcare center you go to, you can certainly mention it to them and say, hey, maybe you want to join this initiative and be part of the future. Healthcare centers will then be able to share knowledge, participate in clinical trials, and be able to refer patients back and forth as needed. If you'd like to learn more about this, we've got a website you can go to. If I figure out how to do that. Down at the bottom of the page, or you just find me sometime during the day. I'll be around all day. Happy to talk about this or share anything else about the patient perspective. So thank you very much.
Thank you, John, and thanks for all the work you do. Okay, now, our next presentation. Coming forward, Amy Liebman, who probably needs no introduction for all of you. She's president of NTM IR, Information and Research, the nonprofit, not-for-profit organization for youth, for patients with NTM disease. I've known her for a long time. I know her father, Philip. He and Fern started the organization many years ago. And we were discussing last night, helped bring me to this institution because Fern was a patient here for many years. And I saw the work and passion and commitment that they put in to start NTMIR and many other support groups across the US. They didn't exist when this all began. She is now running the show, and she's going to talk to us about NTMIR.